Good afternoon, everyone. I'm Dr. John Shrigley, the clinical lead for the Synoptic Pathology Project for Cancer Care Ontario, and also the clinical lead for the Synoptic Pathology Program through the Canadian Partnership Against Cancer. On behalf of Cancer Care Ontario, the partnership, and the Canadian Association of Pathologists, I would like to welcome everyone to today's educational session on the new CAP checklist for endometrial cancer with Dr. Dean Daya, our guest speaker. Before I introduce our speaker and we get underway formally, I'd like to take care of a few housekeeping items. Firstly, today's presentation will be approximately 90 minutes in length and will include about 60 minutes of presentation time to be followed by 30 minutes of questions and answers. The session is being recorded and will be made available to all participants via email links once the recording becomes available. Both the live presentation and the recorded presentation are eligible for CME credits upon completion and submission of the evaluation forms electronically. The recording of the CME credits ends 1 month after the presentation. The information for accessing the evaluation form was provided in the notice for this session previously distributed. Please note that everyone's line has been automatically muted for today's presentation, and we request that you hold all your questions until the Q&A portion of today's presentation. Due to the large number of participants, we are unable to troubleshoot any WebEx connectivity issues as part of this call. If you are having difficulties accessing the WebEx portion of this teleconference, please call the WebEx support line at 1-866-229-3239. During the question and answer portion of today's presentation, I would like you to use the chat section of the WebEx to pose your question. For instructions on how to use the WebEx chat window, please refer to the documentation previously distributed. In order to avoid any question collisions, I will pose the submitted questions on your behalf as long as time permits and in the order they appear. I would ask you in the chat window to please include the following information: 1, your institution's name, your name, and finally the question. It is now my sincere pleasure to introduce Dr. Dean Daya, our speaker for today. Dean Daya is a professor in the Department of Pathology and Molecular Medicine and in the Department of Obstetrics and Gynecology at McMaster University. He received his MD degree from Tanzania, and he also has a Master's of Health Administration degree from the University of Ottawa. I think Dean is well known to most people in Canada. He's a senior pathologist at Hamilton Regional Laboratory Program in Hamilton, Ontario. And Dean has contributed immensely to the literature in gynecological pathology and has given a number of presentations at many organizations, including the ASCP, the Canadian Association of Pathology, and the USCP as well. He's a member of multiple organizations and has been very strongly supportive of education in pathology across the country. So without any further ado, I'd like to introduce Dr. Dean Daya to give our presentation on the overview of the 2010 CAP checklist for endometrial cancer. Dean?
Thank you, John. I appreciate this. So I guess I have to begin with the necessary items, which says about the disclosure information. I have no financial relationship to this to disclose. Something which is missing on this item, which I should have mentioned, and I should mention, is that I am related to Bill Gates and Warren Buffett, but they are both categorically denied my existence. So obviously I cannot claim any money from them. So having said that, I think we should move on. Dr. Shrigley obviously has already mentioned about the questions, which will be at the end of the session. Now the objectives of this presentation would be to use the proper use of the current CAP protocol for endometrial carcinoma. Secondly, I would like to discuss briefly about the preparation and handling of the specimen, which in some respects is as important, if not more important, than really filling out the synoptic. And Dr. Shrigley had asked me earlier that I should discuss some common diagnostic issues vis-a-vis endometrial cancer and how to resolve them before filling out the synoptic report. I should mention that I will be using the official document of the AJCC-UICC GNM classification, the 7th edition, which has also been ratified by the FIGO 2008-2009 annual report. I won't be using any hybrid formats. For example, currently we have a hybrid version in our hospital, but I'm told by the powers that be that as of March of 2011, at least in our center, we will only be using the College of Pathology official document for all sites. And so I think rather than discussing whether this is the right format, I personally like it. I think obviously a few minor adjustments could be made, like in any other systems, but I'm specifically going to stick to this particular format, and if there are some issues towards the end, I'll be happy to address them. So I will show you this slide first, and maybe you can look at it for maybe 3 seconds, and then this one, and maybe you can visualize and tell me as to what is the grade of this endometrial carcinoma. And I hope that you answer in your own mind that it is impossible to grade this tumor. And it's impossible to grade this tumor because this is an autolyzed specimen. With that in mind, let's discuss something about the handling of the specimen. I think whenever there is any adhesions or tumor nodules, one should mention. One should also mention whether the serosal surface is smooth or granular, and I'll be talking about that momentarily. I find sometimes after they've opened the endometrium, there is a tendency to wash and run your finger on the mucosal surface, especially on the cervix. I don't think this is a good idea. In our center, we have made a routine to ink the parametrial and paracervical margins, although this is not actually required by the CAP protocol. Perhaps the most important thing is really one is to make sure that the tissue is fixed overnight. Now, in our lab, we have trained the gynecologist quite well. They send us the tissue fresh, as you see over here. It's a nice shining serosa, and we actually, for the sake of uniformity, paint the resection margin, which is actually the paracervical and the parametrial margin, as you see in this picture. And then we open the specimen from the laterally from the 3 o'clock and the 9 o'clock position. And this is the fresh specimen that you see. This is the cervix and obviously the endomyometrium. And after having done that, by the way, we have the best PAs in the world, Mr. Russell Rogers and Steve Tomasic. So, we work all together. And honestly, if you don't have good PAs, I think life can be miserable. I'm showing this to you. This is actually not a uterus, but this is an ovary. But the point I'm trying to make is it is not uncommon that you get a specimen, and the surgeons have a tendency to stick the hysterectomy specimen in the smallest jar available in the OR, such that there are only 3 mL of formalin. So when that happens, one should remove it and put it in a big jar like this so that the ratio of formalin to the hysterectomy specimen is approximately 10 to 1. I think if you do that, your fixation will be very good. Then you look at the specimens the next day. This is what you would see as the fixed specimen of the earlier shot that I showed you earlier. And then the question is, the residents ask and people ask me, how many sections should I take? So let me tell you, there is no magic answer. There's nothing no one has actually done a study, but I will tell you what is in the books and what we do in our institution. This particular diagram is from this book by Susan Lester, which actually the residents introduced me to this book, and it's a great book actually, and for many different reasons. So as you can see, this is how you open the uterus, and it is laid out as follows. Now in this book it is suggested that you take 1 section from the cervix and 2 full thickness sections of the tumor, as you see over here, 1 section from the lower uterine segment, and then there are sections of the fallopian tube, 1 from the ovary. She is suggesting that when you take sections of the fimbriated end, you should actually use, if you will, a modified CFIM protocol where you cut the fimbriated end and then you longitudinally section, the idea being to maximize the area that you're looking at and if there is any in situ carcinoma. As you know, there's a big buzz right now that the origin of most pelvic carcinoma could be in situ fallopian tube carcinoma. So I think this is an interesting way to look at this. In our lab, we do not completely submit the fallopian tube. We have done it for a project. But right now, we are actually taking one section from the center, and we are actually taking the fimbriated end and cutting them into several longitudinal sections. So at the end of the day, this is what you would get from, say, each side, the anterior and posterior. This nice picture was given to me by Steve Tomasic. Now, what we do in our lab, we actually take twice as many sections than what is actually kind of recommended in the book, such that we take 2 sections of the cervix, 1 section from the lower uterine segment, and 4 sections of the endomyometrium. And frankly, the reason that I prefer this, because the 2 important criteria is the depth of myometrial invasion and cervical involvement. And if that is the case, you might as well maximize on that. You know, the breast pathologists take about 30, 40 sections. So if I take 15, 20 sections, I don't think you can blame me for that. I like when you are actually dictating, rather than giving a paragraph, it's nice to list, as you see over here, section 10, anterior cervix, section 11, posterior cervix. It's easier to read when you look at the sections the next day. So I think this is something that I would recommend. By the way, going back to taking the number of sections, Dr. McLaughlin was here, I think 2 or 3 weeks ago in Hamilton and gave us a great talk about streamlining GYN specimens grossly. And I think in London they take 3 full thickness sections from each side. We take 4. Like I said, there is no magic number, and all practices are different, as you probably recognize. Now, what I've done is, as I said, I haven't altered a single sentence from the CAP report because I think this is the official document. This has been endorsed by the CAP. By CAP here, I mean the Canadian Association of Pathologists. And I think we have to learn to actually use it, but use it properly. So as far as this is concerned, it's just the usual thing. You just pick whatever specimen that you receive. Now, you may be hearing some strong background noise. I sincerely apologize for that. There is some construction going on in our hospital, and there is no way we could have stopped that. I tried to bribe them, and I said, I'll buy you some pizza if you go somewhere else. But they said to me, that's not possible, actually. That's too cheap. But anyway, so I hope you guys can hear me. But there may be times when I think the hammering might be stronger than my voice. The next part, as you can see in the category of the CAP synoptic report, is the procedure. And it is telling us to select all that apply. Now, a point that I would like to mention, which is very important and very useful, that if you look at the CAP synoptic report, there are 2 components. There are components like this, and that at the end of the CAP report, there are notes A, B, C, D. Those are very, very useful notes, and I highly recommend that you read them when you run into difficulties. Obviously, this is not unique to endometrium. If you read about testis and prostate, there are diagrams, so I really like them. I think that the people who have put them together have done an amazing job, and it's really very, very helpful. Now, obviously, most of the time, you will be just using the simple hysterectomy and the ovaries and fallopian tubes. I won't go into the details, because I think really this is self-explanatory. As far as some notes are concerned, again, derived from the document and my personal feelings about this, there may be times when you may actually receive what they call a supracervicular hysterectomy. That's the official term in the CAP. I prefer the term subtotal hysterectomy. And this may happen especially when the surgeons are doing a laparoscopic surgery, which is not uncommon, or if the procedure is so difficult that they have to remove the hysterectomy in 2 components, so they remove the body of the uterus and then the cervix. Lymph node sampling, again, is quite simple. Essentially, you just have to fill out. Most often, when we get them, they are pelvic or para-aortic lymph nodes. Specimen integrity, 90% of the time, the hysterectomy specimen that we receive is an intact specimen, so you just have to kick this. Sometimes you may see a morcellated specimen. And I think the significance of morcellation technique in unsuspected endometrial carcinoma is not known, but I think there is a theoretical risk of spreading the tumor. And in fact, I saw one case, but unfortunately I didn't take a gross picture. This was a really morcellated specimen, Russell, you may remember that. And when you looked at the specimen outside, when you look at microscopically, there was a lot of tumor in there. So I think it's important to mention that. And secondly, there is no choice. This is a mandatory field in the CAP guidelines. The next category is the tumor site. And this is an optional criteria, whether it's on the anterior, posterior, lower uterine segment. Now, this is an optional criteria because, frankly, there are no good studies which have shown whether the location of the tumor has any relationship to recurrence or prognosis. Tumor size is a required field in the CAP synoptic report, and you are required to give the greatest dimension. Those who wish, an optional criteria is to give 2 or 3 dimension. And when you cannot, then you may say so. The caveat in the tumor size is that it's actually quite tricky, because when you open the uterus and you see a lesion, sometimes it may be an endometrial polyp, and the tumor which is arising within the polyp may be quite small. And actually, you're supposed to only measure the actual tumor, so you may have to go and revise your description once you see that. Secondly, when you open the uterus, you may see some polypoid hyperplasia, which grossly looks like tumor. But so you have to make those adjustments in your description towards the end. Again, is it a useful criteria? I don't think there are good studies to really categorically answer that question in a meaningful way, but this is a requirement, and therefore we have to do it. This is the histologic type, and this is the WHO classification that we are required to use. Now, let me give you some comments about the histologic type. When you use the word mixed carcinoma, you should make sure that each component represents more than 10% of the individual tumor. It is not uncommon to see focal mucinous differentiation in an otherwise endometrioid carcinoma, and so that does not constitute a mixed carcinoma. And secondly, I think it's important to give a rough estimation. Example, 80% is endometrioid and 20% is serous. In my opinion, whether it's 20% or 2% serous carcinomas are bad, but there are some studies which claim that if the tumor has less than 20% showing serous carcinoma, the prognosis is favorable. Just to remind you that malignant mixed Mullerian tumor or carcinosarcoma is now regarded as a high-grade endometrial carcinoma. It is not a sarcoma, and therefore you have to fill out the synoptic report for a triple MT. Now, having said that, as I mentioned, Dr. Shrigley had asked me to discuss some issues. So these are some selected issues that I would like to discuss vis-a-vis histologic subtyping, especially the recognition of high-grade endometrial carcinoma, and sometimes the difficulty you may have in distinguishing between complex hyperplasia and endometrial carcinoma in a hysterectomy specimen. Now, I wish all serous carcinomas were like this and had this grade 3 nuclei, and life would be so easy for all of us. But life, as you know, is not like that. Sometimes you may see this picture, which is essentially what you call a glandular variant of a serous carcinoma, where you see this compressed slit-like pattern, a very useful pattern on gross picture. But however, when you look at it under high power, these are really ugly, bad nuclei with a very high NC ratio, as you see in these last 2 pictures. So when you see a a glandular lesion with a disproportionately high-grade nuclei, I think one should think of a serous carcinoma, and then obviously you may have to do some necessary staining. As far as staining is concerned, let me mention it very quickly that in terms of diagnosing serous carcinoma and using P53, when we say positive, this is what I mean when we say positive. It should be extremely strong and diffuse like you see here. You can do a P16 and it's exactly the same thing. It's strong and diffuse. Can I actually minimize that or no? I don't know. Something like this, P53 weak, this is not regarded as positive. I get these cases in my consult and they say, this is serous carcinoma. So if it is like this is positive for P53, but it's not a serous carcinoma, and likewise for P16. Another issue that I would like to discuss briefly is the presence of a serous carcinoma arising within an endometrial polyp. This can be quite treacherous, and my opinion and my request to you is when you see an endometrial polyp in a postmenopausal patient, I suggest that you submit the entire endometrial polyp, because these areas you could misinterpret as actually hyperplasia, or really when you look at it on the high power, this is a serous carcinoma. This is actually not uncommon when you actually look for it. And when you do the P53, it obviously lights up like a Christmas tree. Sometimes you may just see staining the surface of an endometrial polyp, but look at the difference in the staining intensity, the hyperplasia, as opposed to the underlying complex hyperplasia in this polyp. Now, not everything which is papillary is serous, and a case in point is this particular case, which looks papillary. But really, when you look on the high power, this actually endometrium has an endometrioid morphology. But obviously, when in doubt, you can do some immunohistochemical staining. We looked at this study with Dr. Osani, who is right now in Oakville, and the senior author is Dr. Onuma, to see if we can use immunohistochemical markers to distinguish between serous and endometrioid carcinoma. We presented this a couple of years ago at the USCAP meeting, and I think Dr. Onuma is in the process of writing the manuscript now. Bottom line is that if you have a positive P53, a positive P16, and a negative progesterone receptors, I think it probably will pick up 90% of your serous carcinoma. Caveat, however, is that if you have on histology a tumor which looks serous, it smells like serous, it walks like serous. If the immunos are negative, it is still a serous carcinoma because histology is still the gold standard. Moving on to some other high-grade issues, something which I face in my consult practice is it clear cell or no clear cell? Now, obviously, this is a no-brainer. You see this as a typical clear cell carcinoma, this angulated nuclei, very nice borders, typical clear cell carcinoma. However, in the differential diagnosis is also endometrial carcinoma showing squamous differentiation, as in this case, where you see that the nuclei actually not as bad as I showed you earlier. And in the surrounding areas, which is not shown here, you will see typical features, maybe in the corner as of a typical endometrioid carcinoma. Recently, Dr. Silva and Dr. Young have written a paper about endometrioid adenocarcinomas of the endometrium and of the ovary, showing clear cell changes, as in this particular case. Now, when you look at this picture, the nuclei are actually quite round. They have some clearing, but they do not have this high-grade nuclei that you see in a typical serous carcinoma. Now, the prognosis of this particular lesion is similar to all the endometrioid carcinomas. And obviously, there is the so-called secretory carcinoma, where you see this picket fence nuclei. And again, this is a variant of endometrioid carcinoma with an excellent prognosis. This is what has been captured in the CAP notes, the distinction between complex hyperplasia versus endometrial carcinoma. I frankly do not want to go into the details of this because I don't think it is the purpose of this dialogue. Suffice it to say that these are the criteria which are listed, which in fact are modified criteria from the seminal paper of Kerman and Norris in Cancer in 1982. There is no more measuring whether this is less than 2 millimeters or more than 2 millimeters. So, but the reason I'm actually showing this is if you have a hysterectomy specimen and you are really struggling, is that cancer or is it hyperplasia? My preference is to call them complex hyperplasia, residual complex hyperplasia with atypia. If I can avoid, I don't want to give a carcinoma diagnosis in a hysterectomy specimen. Conversely, though, in a curettage specimen, my threshold is lower. So obviously, if I'm suspecting carcinoma, then I want to make sure that the clinician knows about it so that the right surgery is done. Okay, moving on, let's talk about histologic grade. Now, again, we are required to use the FIGO grading system, which is listed over here, specifically for the endometrioid and mucinous. In the CAP synoptic report, they say for other carcinomas, you may use this particular category, although, frankly, they haven't amplified this. I don't use this. For example, if I'm reporting serous carcinomas, I don't grade my serous carcinomas. To me, they are all bad, as I mentioned. You are all familiar with this picture or diagram or table denoting the grade, 5%, more than 50%. I won't go into it. Just to show you a few pictures, this is an illustration of a nice FIGO grade 1 endometrioid adenocarcinoma showing nice glandular component. They are on higher power. On the other hand, solid areas sometimes can be quite difficult to determine, and that's why there is some subjectivity. But in my opinion, this would be regarded as a solid component, and this would be regarded as a glandular component. But I have to admit that it can be quite difficult and challenging at times. Not to forget that there is obviously squamous differentiation in an endometrioid carcinoma, which should be discounted from your grading system because squamous component is not graded in endometrioid carcinomas. And just to put you at ease, this was a study in histopathology some years ago, looking at the concordance of FIGO grading system in biopsy and hysterectomy specimens. And as you can see, the concordance is absolutely dismal. Concordance is only 45% in grade 1, higher obviously in grade 3. But the author said that the predictive accuracy, irrespective of the biopsy type, the patient's age, the interval between hysterectomy, and who reported what doesn't mean anything. It's still quite bad. So don't worry about it too much, but try to do your best. Again, going back to the grading, serous, clear cell, and small cell and undifferentiated are not graded using the FIGO system. So in the table, when you have these carcinomas, you just check or tick not applicable. Now, let's move on to another big problem in endometrial cancer, and this is a huge problem regarding the depth of myometrial invasion and how to measure it accurately. Again, this is the table in the CAP synoptic report, identified, not identified, present. And I think the synoptic report is asking us to give the depth in measurement in millimeters and the thickness of the myometrium. And it says that if you cannot, then you obviously just have to say whether it's 50% or more than. Now, some people actually don't like it. I think people are more interested in the bottom line. They are saying, just tell us. Clinicians say, just tell me whether it's more than 50% or less than 50%. I think both parameters can be useful to arrive at the diagnosis. And let me illustrate this for you. I should also mention, for example, in our institution, the gynecologists love to have the percentage of myometrial invasion. It's not a requirement, and that's why I put this as an optional criteria. And then there is this, I would think it's a nuisance. This is carcinoma involving adenomyosis. According to the CAP protocol, and I will show you some example, this should not be interpreted as invasive adenocarcinoma. Special stains, according to CAP and my personal experience, is that it's frankly not very helpful. There are some papers which say that it can be helpful, specifically CD10, but this is not my experience. This is a paper in International Journal of Gynecological Pathology, 2007, from Soslo's lab, talking about the difficulties in assessing the depth of myometrial invasion. So this is a well-recognized field, as you know. Now, this particular diagram, or this particular picture, is actually from that article that I showed you. And this diagram actually is in your CAP synoptic report in the notes section. All I've done actually is I have actually made the tumor red. Ashwin helped me put all these colors in it just for the sake of making it more clear, so to speak. Now, let me take a minute and explain this diagram to you. It's not as complicated as it seems. This is your endometrial cavity. Here is your endomyometrial junction. So if there is tumor here, you simply measure the depth of invasion from here down to here. But very often you have an uneven endomyometrial junction, in which case it is recommended that you measure your depth of invasion from here to here and not from here to there. Sometimes we have an exophytic tumor, not at all uncommon, in which case you actually draw an imaginary line. You don't measure from here. It's very important because you overestimate your depth of invasion. You measure actually from here down to here. And likewise, if you see tumor here, but there's another focus, then you obviously measure the maximum depth of invasion. This last diagram depicts actually adenocarcinoma arising in adenomyosis. And in and by itself, really, the prognosis is still very good, going by the bulk of the literature which is available. If you see a tumor which you think is arising from here, then Soslo is saying you can measure it from here. Other people actually are saying it's safer just to measure it from here to here. We don't have clear-cut guidelines of that. All I can tell you is that it's a rare thing, and perhaps people talk too much about it more than really necessary, as I'm doing right now. The significance of tumor involvement, this has recently been addressed in the September issue of International Journal of Gynecologic Pathology from Mark Solos group. And this actually are pictures from that paper. Here you can see the endomyometrial junction, and even here there is adenomyosis. You can see the normal glands and adenocarcinoma arising within it. So in and by itself, really, I don't think it has any major prognostic significance. There was a paper actually from Sunnybrook, from Nadia Ismail and Dr. Khalifa. As I said, this is a controversial subject, and I think in their paper, they seem to indicate that if the foci are deep, it may have some prognostic significance. Is it invasive or non-invasive? Again, there are no clear-cut guidelines, but I guess the issue is if the border is smooth like that, then this is really carcinoma arising within adenomyosis. But if you have an irregular border with some lymphocytic infiltrate, then this is most likely an invasive adenocarcinoma arising within adenomyosis. Now, again, going to the depth of invasion, it's best to actually look at your sections, and then I don't make too many measurements. I like to eyeball. I think most people do that, but sometimes you may have to measure, as I mentioned earlier. This is an interesting case. Both slides are from the same patient. Here's your endomyometrial junction. Now, you draw a curved line because it's a curved specimen. So obviously, if you draw a line from here to here, you will say there is superficial myometrial invasion. In this particular section, you don't see that, so this one would illustrate that there is a deep myometrial invasion, meaning more than 50%. So, but these are real-life problems from a real-life case, and I guess we do our best. But I think it's important that when you have a tumor like this, you don't measure from here to here. You have to say that this is my endomyometrial junction. Here is another case slide provided to me by Russell. Here is the smooth muscle. This is most likely the surface. So you can draw a line, or you can, this case is from outside. And then you look at the, now this particular person actually measured it from here. I would have probably measured it from here because to me this is still endomyometrium. See what I mean? This can be quite subjective, and as I mentioned, this is a difficult case. And if I were to do that, then obviously this would be a deep myometrial invasion. This is a very interesting case. Dr. Litwin, my partner in crime, showed me this case about a couple of weeks ago. This case came to us from an outside lab, and the question was the depth of invasion. It said the depth of invasion was 80%, and you can understand why. You see this tumor. Is this the actual serosa, or is this the serosa? It's very difficult to tell. Is this smooth muscle? You can see some fat here. So let's look at this under high power. If you really look at under high power, you do not see smooth muscle. This is actually a granulation tissue myofibroblastic response. When Dr. Litwin first showed me this case, I really frankly wasn't impressed. I said I have to look at it under my own microscope, and went and pulled out 3 cases of endometrial cancer. And really when you look at the serosa, you see obvious muscle and a sort of a serosa over here. It doesn't look like this. So that was my first suspicion that the tumor could have extended beyond the serosa. She was kind enough to do some immunostains, and as you can see, desmin is actually quite negative in this myofibroblastic stroma, and there is a nice inbuilt control of the smooth muscle. Now, this is obviously quite important because once the tumor is outside the serosa, this then becomes a stage 3 disease, which has major implication in terms of subsequent therapy. Here's another interesting case I would like to discuss with you, and what I want to show you, this is a large endometrial cancer. This is a serosal surface. I always tell my PAs that you really have to take many sections of these adhesions on the serosal surface. It can be something as simple as endosalpingiosis, as in this particular case. It could be endometriosis sometimes, but in this case that I'm showing you, this turned out to be actually cancer. So here is your, if you will, your serosa, and this is the tumor, the adhesions that I showed you earlier. You can hardly see something, but you see some mischief going on in here, and high power shows obvious carcinoma. So this tumor obviously had extended outside the serosa. Now let's move on to a more, again, another difficult area, which is involvement of the cervix and creates a lot of issues for us. This is the CAP report here, which says involvement of cervix. Select all that apply, not involved. Invasion of cervical stroma. Now this is different from the last AJC, which was a 6th, where, as you know, surgical stage was divided, 2 was divided between A and B, i.e. whether it was glandular and surface versus stroma. In the 7th edition, fortunately, we don't have to deal with this issue. A lot of my referral cases was, is the cervix involved? Is the tumor just sitting there? Or is it true invasion? So now, the only true cervical involvement is the presence of stromal invasion into the connective tissue. So just reiterating, this was the old one. The new one only requires stromal invasion. So something like this, we can safely say, don't worry, be happy. This is no more stage 2 anymore. What is important is to recognize this kind of pattern where you see a stromal response deep or within, obviously, in the substance of the cervix, and overlying epithelium showing normal endocervical stroma. So if you see this, and below that you see this, this would be a true involvement of the cervix. Now, just to caution you and kind of to bring you to your awareness, a relatively unknown entity, and maybe that's the reason why I like to take 4 sections from the cervix. There was a report from the MJ Search Path about endometrioid carcinoma invading the cervix, which has a deceptively bland pattern, as in this case. This was a case from outside, which was actually it was not reported as involving cervix. So here are your Nebortian cysts, and you see some glands which look very benign and actually innocuous. You can see that on high power you see these glands which hardly have any stromal reaction. But actually this is an endometrioid adenocarcinoma going deep into the endocervical stroma, and obviously this would be a stage 2. So I just want to bring to your awareness about this entity. Now, this issue about, depth of invasion, cervical involvement is nothing new. As you know, Dr. Khalifa had reported this, I think it was in 2003, when they looked at the slide review, and I'm only going to talk about the pertinent issue vis-a-vis endometrium. The presence and extent of myometrial invasion was probably one of the biggest issues, followed by the typing of endocervical carcinoma. We have just completed a similar study looking at 2 cohorts of 1997 to 2006, just to see if we have made any improvement. And unfortunately, if you really look at the depth of reporting of the depth of myometrial invasion or interpretation, it really hasn't changed from 1996 to 2007. In fact, it has marginally increased, although I don't think it is statistically important. Cervical involvement, 7%, 31%. So I think assessment of myometrial invasion and cervical involvement is still an issue, and we have to actually pay much attention to that. Just to bring you up to speed, preparing this lecture actually has been very educational for me. You get to, review the literature, and, until the last minute you're looking for stuff. So I just found this in this month's issue of Obstetrics and Gynecology. This is a paper from Mike Stoller's lab, entitled Cervical Stromal Invasion Predicting Survival in Endometrial Cancer. And really, to cut a long story short, they are saying that only deep, outer one-third cervical stromal invasion is an independent predictor of death in stage 2 cancer. Superficial cervical stromal invasion did not increase the risk of death. So just to emphasize, it's the deep myometrial invasion which really is important, but obviously we need more studies to really verify something like this. Now, another problem, which sometimes actually is a bigger problem than cervix, is, I get this case consultation. Is this involvement of the upper endocervix or lower uterine segment? It's a big issue. How does one go about sorting it out? Well, as you know, fortunately, uteri don't come with lines drawn to say this is cervix and this is lower uterine segment. They kind of merge together. So if you see these kind of glands, which are kind of, I think there's a high power of that, look like ciliated glands, and you see tumor here, this is involvement of the lower uterine segment. This is not involving cervix. For me to say cervix is involved, I actually have to see cervical glands here and tumor here. Without that, I would not call it cervical involvement. Okay, moving on. I think I'm doing okay with time here. Extent of involvement of other organs. Again, this is from the CAP synoptic, nothing much to report. You obviously are supposed to just tick whatever is involved. There is a very timely review, as I may mention this, and since Dr. Shrigley is also listening to this, I think in the archives of pathology last month's issue about the usage of the term involved and not involved, it's a very timely thing because there are some mistakes made in the reporting and interpretation. So the authors are saying it would be good that we don't use this term. We should just say benign, or we should say negative for positive margins. And I think this is not only for endometrium, obviously, but it is across the board for reporting any cancer. So I'm just plugging in for that because I do believe in that. Extent of involvement of other organs, these are optional. My take on this, and in our institution, anything which is optional, we do not include in our synoptic report because it makes it unnecessarily long. the clinicians go a little crazy, so we tried not to actually do that. Okay. So anything which is with an asterisk, we have decided not to include them. My secretary has just brought me a note here that I should slow down a bit because there are technical issues at some sites. So I will try to slow down, but I hope most of the time, I guess there are some people sitting in this room. Am I speaking too fast? A little bit? I could slow down? I'm okay? Yeah? All right? Okay. I have residents sitting here. I forced them to come, and I fed them with pizza. So now they have to stay and listen to the entire presentation. Again, extent of involvement of other organs. This is, again, an optional criteria, and I don't think you need to talk about this unless, or mention this, unless you obviously have a specimen including omentum. And same thing actually goes for this particular category. Actually, I'm starting to talk slowly now. You know, I don't want to make it too slow. Then it's going to take too long. Peritoneal washings. This is an optional criteria. This is a big difference now from the earlier version. As you know, in the last, this would be a stage 3, but right now it is still actually part of stage 1, and it's an optional thing. So you are supposed to essentially mention whether it is positive. When you are supposed to just mention whether it is positive or negative. I think the issue about this is that there are no good papers about the prognostic significance of peritoneal fluid. And as you know, it really does not alter the stage, but should be recorded in the report. Margins. Now, margins is a big issue only because it is a pseudo issue. In the CAP, it says cannot be assessed, uninvolved by invasive carcinoma, and then you're supposed to measure the distance if it is there. So even in the earlier version of the 2003 report, when they asked us to talk about margins, people started calling me frantically as to what margins are we talking about, because traditionally we never report margins in a hysterectomy specimen. So I want to talk about what margins are we referring to. So this is from CAP. The only true margin is really the paracervical soft tissue. This is the only true margin in a total simple hysterectomy specimen. And the reporting of the status of this margin currently is really not performed. So it is an optional thing as we speak. So in a case like this, which I showed you, this would be the actual margin. Okay. This would be the actual margin. And that's why they ink them. But 99% of the time, really, there is no tumor. Conversely, the CAP says that reporting the status of the vaginal and parametrial margin in a radical hysterectomy is optional. I think it should be not optional, it should be compulsory, because if it is a radical hysterectomy, this procedure is done for a stage 2 endometrial cancer. And let me show you an example. One should mention it. For example, this case here, you see a hysterectomy specimen. You don't see much over here, but these are actually the parametrial and paracervical margin. Actually, this is not a very good operation, I must say. Usually, you should actually get a lot more tissue on each side, but this is a radical hysterectomy. And this is just the front of the lesion. So in this particular case, the true margin would be obviously these margins here, this margin here, which we like to paint. And in a radical hysterectomy specimen, there are these vaginal margins, which obviously need to be painted, and we have to let them know which is involved. But just to emphasize, the cervix is not the margin, and the serosa of the uterus is not a margin. Lymphovascular invasion is pretty straightforward. You see it or you don't see it. However, there are some artifacts that I would like to discuss. Firstly, let me mention that involvement of lymphovascular invasion does not affect the T category, but its determination is not always easy. You may have to do some immunos, and even immunos may not be very helpful. There are some retraction artifacts. Is it useful? We don't know. There are some centers and there are some papers both here and in the United States where if you do demonstrate and report lymphovascular invasion, patients will get radiotherapy. In Hamilton area, this is unfortunately or fortunately, this is not done. But let me show you some artifacts. This really could be like a lymphatic invasion, but it isn't. This is very significant retraction artifact. And as you can see, it can be quite significant. So you may wish to do immunohistochemistry in some of the cases. Another artifact which does occur is in this case, where you see that, especially if the tumor is autolyzed, when you're cutting it, it may artificially get in between these places. This is known as the toothpaste phenomenon. Actually, it has been described as, I didn't know about that. So one has to be careful not to interpret this as actually a cancer. Here is another case, which frankly is quite difficult, but really, I'm only showing you a couple of quotochromes, but when you look at the entire case, this is actually just tumor sitting in the middle of nowhere, and this is really not invasion or lymphovascular invasion. Okay, we are getting towards the tail end of the issue, and this is regarding staging issues. Now, there is the AJCC staging system, which is in a way required by the CAP, and gynecologists are funny people, gynecologic pathologists included, because they have their own classification, which is the FIGO or the FIGO classification. But I think fortunately, in the current version, the AJCC and FIGO have decided to sit together, and they've agreed to actually synchronize, if you will, their classification. So here you see the TNM category, and here is the FIGO category, and actually they coincide pretty well. In terms of the reporting, I use both. I use the TNM, and I would say TNM 2009, and I would say FIGO 2009, as the case may be. When I say, I'm talking of the bottom line. Let's talk very briefly about the presence of synchronous uterine and ovarian endometrial carcinomas. It is not an uncommon problem. You may sometimes have a hysterectomy specimen and an ovary which is involved. Now, obviously, if the tumor in the the tumor in the endometrium is endometrioid, and the tumor in the ovaries is serous, it's quite easy. But most of the time, the tumor actually look quite alike. And then the question is, how do you tell what is coming from where? And I'll discuss this very briefly. But there is a paper by Irving et al. Which mentions that if there is nuclear staining with immunohistochemistry for beta-catenin, then it's restricted as an independent uterine and ovarian primaries, as this particular marker was not seen in any of the metastatic carcinomas. Now, I have, frankly, personally not used this marker as yet, so I cannot tell you much about it. I like to use these three diagrams, and I let my residents. This is from Clement's book, Clement and Young, which in my opinion, if I'm a plug-in for them, is probably the best GYN text available. And what they have done is they have these three charts in there: endometrial tumors of the ovary and endometrial primary ovarian secondary tumors. And essentially it's really gross description and microscopic description. Where is the tumor? Where is the bulk of the tumor? If there is a large endometrioid tumor and small ovarian primary, then most likely this is an endometrial primary. Is there deep invasion? Is there direct extension into the adnexa? Is there a lot of vascular invasion? Is there tumor elsewhere? Now, I'm not going to go into the details of this, but I think this is a table that I like, and this is another table which has the opposite side. Is the tumor of ovarian origin? Is it primary ovarian? And endometrial secondary? Again, look at where the bulk of the tumor is. Location within the parenchyma. Is it bilateral? Does it have atypical hyperplasia within the endometrium? And obviously, in some cases, you may have to do some DNA and aneuploidies stuff, but these tumor markers are not easily available to most labs. So I'm not, again, as I said, I'm not going to go through this. Suffice it to say that you can certainly read in this particular book. But what I would like to emphasize, ladies and gentlemen, that when you are in this scenario, in my experience, probably 80 to 90% of the cases are actually separate primaries. And I guess the proof of the pudding is actually the prognosis is excellent when you look at this kind of cases. Okay, the next category is regional lymph nodes. Nothing much to say here, except to say it is important, obviously, to specify whether it is pelvic or para-aortic. This is now regarded as a C1 or N1, N2 in the TNM category. And there are some recent papers which say that if the para-aortic lymph nodes are involved, then the prognosis is actually worse. Distant metastasis is kind of self-explanatory. I'm not going to talk much about it. What I'm going to tell you, though, which is not mentioned in the TNM document or the FIGO document, is sometimes you get omentum, and the omentum shows carcinoma. And then the question is, well, where do you put it? Well, the HACC and FIGO actually doesn't have anything on it as yet, surprisingly. But when I talk to my gynecologist, and I've talked to several of them, if you see tumor in the omentum, this is regarded as a T4 disease. So it's a big issue. Additional pathologic findings is the next category. This is an optional criteria. You may wish to include this in your synoptic. We do. There's even a category of the endometrial hyperplasia, neoplasia terminology. And those of you who are comfortable, you can certainly use it. Ancillary studies, I think by this what they mean is that if you have done any special stains, then I think you are required to mention this, or not required, actually this is optional, I should say. So for example, if you have a case and you are deciding, is it of endometrial origin or endocervical origin, is it serous carcinoma, is it endometrial carcinoma, that would have to be filled out in the section of ancillary studies. So you mention the stains that you have used and obviously their interpretation. But since I have time, or I'm just almost there, I think I have 3 more minutes, this is a case which was submitted as an endometrial carcinoma, and you can understand why. It obviously has this endometrial morphology, but the nuclei kind of look very dark. It's subjective. You don't see those vesicular nuclei. There's a high power. I guess something made me suspect that this could be endocervical. This is ER. Some of them are staining positively, not all. This is vimentin. The tumor cells are essentially negative. This is CEA, which is actually quite positive in the cytoplasm. This is P16, and it just lights up like a Christmas tree, both in the cytoplasm and in the nuclei. And actually, when we did receive the specimen, this turned out to be a tumor of the endocervix, which was extending into the lower uterine segment. So I think sometimes some of these studies may be helpful to determine the site, because the prognosis is different and the subsequent radiotherapy will be different. In the last category, they are talking about clinical history, and this is optional. In that, there are essentially talking about the Lynch syndrome, and I didn't know until I started reading a little bit more about this Colonic carcinoma is the most common malignancy in the hereditary non-polyposis colon, the HNPCC, which is the Lynch syndrome. However, I wasn't aware of, that endometrial carcinoma develops before colon cancer in more than 50% of the cases in patients with colonic cancer. So then the question is, should you do molecular studies? Should you advise the clinician? So I had some discussion with our clinician, and I think we kind of came to an agreement that if you see endometrial carcinoma in a patient under 50, if the patient has signs and symptoms of polycystic ovarian disease, then I don't think you need to send specimen for molecular studies. However, if that is not the case, I think it would be prudent on our part to send tissue for molecular analysis to find out if the patient has those genetic alterations. Now, one more minute, John. I know we are not really supposed to know the details of endometrial cancer, but I think roughly we should have some idea. In our center in Hamilton, this treatment is based on the current AJCC 7th edition, FIGO grade 8. We have grade 1. This is only for stage 1 endometrial cancer, grade 1, grade 2, grade 3. By the way, 70% of endometrial carcinomas are endometrioid and 70% are stage 1. And here's the depth of invasion. If you fall into this category, no further adjuvant therapy is needed. In the intermediate risk, if the surgeon has done lymph nodes and the lymph nodes are negative, in our center, they don't give any radiation. If the nodes are done, then they will offer radiation. In the high risk, if the nodes are done and are negative, no radiation is given. If nodes are done and are positive, then patients will get external beam. As far as treatment of serous carcinoma is concerned, all cases in our center get carbo and Taxol, carboplatinum and Taxol, except in those cases where there is no myometrial invasion. So serous carcinoma is a huge deal. Last section is the comments. I'm just saying to use this section very liberally. I use it. Anything that I want the surgeon to know and hear, I put them in the comment section, because the surgeons tend to use this and read this more than some of the stuff in the synopsis. So this, a couple of last slides. This is a diagram which I saw in the New York Times. This is the picture from, I don't know how New York Times got this, about the situation in Afghanistan. And I looked at it, and it is the most complex thing that I've ever seen in my life. This was generated by General McChrystal, who was eventually fired by Obama. And he said, when we understand that slide, we will have won the war. And I think that's why they're never, ever going to win the war, because you can't understand this diagram. Well, I hope that my talk is not as complicated as this diagram. So with that in mind, I think it is just past 1 o'clock, and I'm going to, first of all, thank CCO and specifically Dr. Shrigley for giving me this opportunity to talk to you. Thank you.
Thank you very much, Dean, for that wonderful overview of the endometrial checklist. It was truly enlightening for all of us. We do have a couple of questions that have come in already, and I encourage other people to type in the questions in their chat boxes on the WebEx screen. So we'll proceed with the questions, if you don't mind, Dean. The first question actually comes from Terry Colgan, Mount Sinai Hospital. Do you use the 25% threshold for a diagnosis of pure serous carcinoma?
By the way, just for those people, some of you, Terry Colgan is a veteran GYN pathologist in Toronto. Terry, I do not use that criteria. I think I have burnt my fingers. I've used that criteria with less than 5%, and I've seen that some of those cases have recurred. And I've talked to a few gynecologists, oncologists, and GYN pathologists, and some of us feel that even if the tumor constitutes 5% of serous carcinoma, it may behave in a very bad fashion. So I don't use that cutoff, and I don't subscribe to that.
Another question came in, Dean, from Raymond Mong. I think Raymond's in BC. I think he's in Kamloops. His question is involvement of the omentum, why T4 and not M1?
When I say T4, I guess I'm using really the FIGO grading system. Like I said, the thing is, omentum is considered outside the pelvis. So once something is outside the pelvis, it is regarded as T4. So for example, tumor even outside the uterus on the serosized T3. Now if the tumor has already gone into the omentum, obviously it is worse. So it is regarded as a T4 by my clinical colleagues.
Okay, we got a question coming in from Sangeeta Joshi in Niagara, and the question is, can we use Ki-67 instead of P53 for serous carcinoma?
I don't know the answer to that very well. I think we did try to use that. I have only anecdotal evidence, and frankly, it will be positive, but I don't know what it means. You see, when you do studies using the Ki-67, it is a matter of how many cells you have to calculate the percentage. But I think Dr. Soslow had done some similar work using the Ki-67. And when you use a battery of tests, I don't think Ki-67 was considered to be a useful marker in delineating serous from endometrial carcinoma. So I don't use it, and I don't recommend it.
Okay, Dean, we got another question coming in from University of Ottawa from Bojana Dvojek, if I got that pronunciation correct. How would you handle a stage T1A endometrioid carcinoma with extensive LVI in the adnexa?
That's a very good question. It's a very difficult question. So the question is, it's a stage 1 endometrioid cancer, and there is extensive involvement, lymphatic involvement in the adnexa. And I guess before I answer that question, I have to actually say to myself, how on earth did it get there? And I don't have a good answer. I mean, my question again to the one who posed this question was, was there lymphatic invasion elsewhere in the myometrium, which could be one of the pathways? I don't know the answer to that. There has been a couple of recent papers where there is artificial so-called pseudo-lymphatic invasion, and these are cases who have had a hysterectomy, laparoscopic hysterectomy. Some of these young surgeons like to do laparoscopic hysterectomy, and they put a balloon in the endometrial cavity, and this puts positive pressure in the cavity. They inflate it, so some of the tumor is displaced into the lymphatics. Frankly, if I had a case like that, and I don't know much about this particular case, I really wouldn't know how to respond. I would still stage it using the current criteria, but this is the place where I would use the comments section. In the comments, I would say what you see, and frankly have a discussion at the tumor boards with your oncologist and make the appropriate decision.
Okay, we got a question from Jeanette Lajoie in Osler in Mississauga, or in Brampton. Would you require patient consent before doing genetic studies for Lynch syndrome, for example?
I have to say, since we have actually not done this, this was only brought to my awareness when I was preparing for this particular talk. So, as we speak, or prior to that, we have not sent any. Would we have to do that? I think we would have to do that, but I personally wouldn't do it. I would just talk to the clinician. The clinician would have to explain to the patient that we are suspecting this, and we need a consent form. Now, in some institution, there is already a generic consent form. So if that generic consent form is there, then you need not take a separate consent form. But if nothing like that exists in your institution, then I think it would be a good idea.
Okay, another question's come in from Sangeeta Joshi in Niagara. Are we supposed to submit the fallopian tube in total?
Yeah. So I guess I had discussed that earlier. Are we supposed to submit the fallopian tube entirely? Something that I didn't mention earlier, Dr. Tang is sitting here. He's a senior author of a study which we just finished of 300 consecutive cases of, we were looking actually for the stick lesions. And the question was, is the incidence of in situ carcinoma in the fimbriated end of the fallopian tube higher in serous carcinomas as opposed to tumors of endometrial origin? And we found out actually that none of the cases which had endometrioid morphology had serous carcinoma in the fallopian tube. However, there is some evidence in the literature and also from our paper that those patients who have serous carcinoma of the endometrium, I think about 7 or 8% had serous carcinoma, or 7 or 8 patients, I think. 14%, Dr. Tang is just correct me that 14% had actually in situ lesion in the fimbriated end of the fallopian tube. Now, this is also a resource issue, Sangeeta. You know, your lab administration, in your particular case, it's not going to be a problem because it's your husband, so he will let you do it. But in other institutions, they will say you are exhausting lab resources. So as a compromise, what I would suggest is the fallopian tube should be cut off and it should be serially sectioned, longitudinally sectioned, with one section from the middle of the fallopian tube. And I think if there is in situ serous carcinoma, quite frankly, you will pick up, because really if there is any mischief, it's always in the fimbriated end. So at this point in time, I don't think it would be a fair recommendation for me to suggest this in all cases of hysterectomy for endometrial carcinoma.
Okay, another question from Dr. Djordjevic in University of Ottawa. Do you think it is reasonable to include lower uterine segment location of tumor in the synoptic reporting, i.e. increased likelihood of Lymph syndrome?
I didn't know if there was any relationship between tumor in the lower uterine segment and Lymph syndrome. Let me ask my colleagues who are usually more educated than I am. We have here Dr. Litwin, Dr. Tang, and Dr. Onuma. Anything that you so slow? Dr. Onuma, oh, by the way, I forgot one slide here. This is the slide I wanted to show you. I'll come back to your question momentarily. I just want to thank too many people, but these are the people that I really wish to thank who have helped me put this talk together, the path assistant, a lot of pathologists who have given me tremendous amount of teaching material. So going back to your question, Dr. Onuma, who was sitting at the corner there, he's saying that Soslow has said that there is a relationship between tumor in the lower uterine segment and Lymph syndrome. I think then whether it should be mentioned or not, I think we need more papers. We need more evidence. And quite frankly, right now, I don't think there is any provision to make any changes. You may wish to do that as an optional criteria, but I am told, like I said, by the powers that be, the best thing, frankly, for me, whenever there is a new classification or a new format, I like to try it out for 3-4 years, collect some data, and then go back to the drawing board. So I can't answer your question very directly, but if you wish to do so, be my guest.
Well, Dean, I don't think we see any other questions here, and I guess that's because your presentation was so incredibly clear that you prevented any questions from coming up. Hold on,
Can you hear me, John?
Yeah, there's one more question coming in now. Hold on.
I guess you can't hear me. Yes, of course.
Okay, here's another question from Kevin Waters. Similar to question regarding submitting the tubes, do we need to submit the entire ovaries in a total hysterectomy specimen with endometrial cancer?
I guess the simple answer is no. There is no evidence right now to say that if you submit the entire ovary, and actually I guess if we submit the entire ovary, the question would be actually what are we looking for? We submit the entire ovary and the fallopian tube for patients who are BRCA1 and BRCA2 positive, because there is a documented evidence of in situ changes in cancer. But I think in a garden variety scenario, I do not think that there is enough evidence or literature to say that we should submit the entire ovary. You guys concur? My friends concur.
Okay, Dean, that's wonderful. So I'll just make some concluding remarks now. On behalf of Cancer Care Ontario, the Partnership, and the Canadian Association of Pathologists, I would like to sincerely thank Dean Daya for a truly comprehensive, informative, and incredibly clear presentation today. This is the first teleconference in our second series of CAP checklist presentations, and we would welcome your comments and suggestions for ways to ensure the sessions are informative and relevant to your practice. Please include your feedback and suggestions as part of the completed evaluations. Once the WebEx recording of this presentation becomes available, it will be made available for wide distribution via links through Cancer Care Ontario, the Partnership, and the Canadian Association of Pathologists. Access to this recording will be available for review at your convenience and is not restricted. As a reminder, both the live and recorded presentations are eligible for continuing education credits. The recording of the credits ends 1 month after the actual teleconference. In order to receive the CME credits for attending or viewing the educational sessions, you must complete an evaluation form for each session accessed and viewed in entirety. The link to the web-based survey has been included in the session notices distributed prior to each session. If you are not able to access the web-based evaluation, please contact Sarah Lancashire at SARA.LANKSHERA@cancercare.on.ca to request a copy of the evaluation form to be emailed to you. This information was also included on the notice distributed prior to this session. Please note CME certificates for each of the CAP checklist education sessions will only be issued 1 month from the actual presentation date. The sessions will remain available electronically for an undetermined period of time, but CME credits will only be issued for a month because of resource reasons. Please refer to the session notice for the exact deadline date. Our next presentation is scheduled for November the 24th, and it's going to be on stomach and esophageal checklist, and Dr. David Dryman from London is going to be our presenter at that particular presentation. I want to once again thank Dean for presenting this wonderful WebEx conference, and I want to thank everybody for their attendance. This session is completed.
I guess